So, welcome to Kanski lecture series, and this is Conjunctiva part 4. And in this part, we are going to discuss about the allergic conjunctivitis. So, let's get started. Allergic conjunctivitis, you know that there is some conjunctivitis that is caused by some allergen to a pollen or dust mite or anything. And one thing is that it is the discharge is usually watery or mucoid. Allergic conjunctivitis atopy is a genetically determined predisposition to hypersensitivity reaction upon exposure to a specific environmental antigen. So it is usually genetics plays an important role in a case of allergic conjunctivitis. Some allergies run in families, so genetically predisposed individuals, and there is a specific environmental antigen that a person is hypersensitive to. Clinical manifestations include the various forms of allergic conjunctivitis as well as hay fever, seasonal allergic rhinitis, asthma, and eczema. So, conjunctivitis can occur with various other problems like hay fever, which is usually a seasonal allergic rhinitis. It can also occur with an asthma. It can also occur with an eczema, which is an dermatitis. Allergic conjunctivitis is a type 1 immediate hypersensitivity reaction mediated by the degranulation of the mast cell in response to the action of the IgE. There is an evidence of an element of a type 4 hypersensitivity in at least some form. So most of the time it is a type 1 hypersensitivity reaction in which the IgE are formed and antibodies are formed against the some antigen, and the mast cells degranulate, and when they degranulate it causes a hypersensitivity reaction. Acute allergic conjunctivitis. Acute allergic conjunctivitis is a common condition caused by an acute conjunctival reaction to an environmental allergen, usually pollen. It is typically seen in younger children after playing outside in spring or summer. Acute itching and watering are common, but the hallmark is chemosis, which is frequently dramatic and worrying to the child and parents. Treatment is not usually required, and the conjunctival swelling settles with an hour as the acute increase in vascular permeability resolves. Whole compresses can be used, and a single drop of adrenaline 0.1% may reduce extreme chemosis. So, what is a acute allergic conjunctivitis? As the name indicates, the acute allergic conjunctivitis present acutely. The patient present for the first time, and it's like an environmental due to some environmental antigen, and basically it occurs in the spring or summer, very important. And what is the sign? There will be the watering, itching, and chemosis. What is chemosis? Marked chemosis. Marked chemosis means that there will be the translucent appearance of the conjunctiva. The conjunctiva appears swollen up due to the fluid. So you can see that bulbing of a conjunctiva due to a fluid inside it. It is called the chemosis, and we usually do it with treat it with the cold compression, and we can give a small single drop of adrenaline. Seasonal and perennial allergic conjunctivitis. These common subacute conditions are distinguished from the other by the timing of exacerbation, thought to relate principally to different stimulating allergen in each. Seasonal allergic conjunctivitis, hay fever, eyes, worse during spring and summer is the more common. The most frequent allergens are tree and grass pollen, although the specific allergen varies with the geographic location. So this type of conjunctivitis usually present with according to the timings of the year. If seasonal conjunctiva usually present in the spring and summer, and basically there is an allergy to the trees and grass pollen. Perennial allergic conjunctivitis causes symptoms throughout the year, getting worse in autumn when exposure to the dust, house dust mites, animal dander, and fungal allergen is greatest. It is less common and tends to be milder than a seasonal form. So, perennial allergic conjunctivitis basically occur in whole of the year, but it is most worst in autumn. And what happens, it is allergic to house dust mite, animal dander, and the fungal allergen. Diagnosis. Transient symptoms are the transient, acute, or subacute of redness, watering, itching associated with sneezing and nasal discharge. So, sneezing and nasal discharge can also occur with it. Normal vision, conjunctival hyperemia with a relatively mild papillary reaction, variable chemosis, and lid edema. So, remember that in a case of the allergic conjunctivitis, papillary formation is more. So, always remember that papillary conjunctivitis. So basically, a conjunct with a papillary reaction is more in the case of an allergic conjunctivitis, variable chemosis, and lid edema. Investigations are generally not performed, although conjunctival scraping in more active cases may demonstrate the presence of eosinophil. Skin testing for particular allergen is rarely required. So, conjunctival scraping will demonstrate eosinophils. Treatment: artificial tears for mild symptoms, mast cell stabilizers, antihistamine, dual action antihistamine, and mast cell stabilizer, combined preparation, non-steroidal anti-inflammatory preparation, topical steroid, and oral histamine. So we will look at one by one. Artificials are given, tears for given for the mild symptoms. So there are certain kinds of the anti-allergic treatment that you may give to a patient that comes with a case of allergic conjunctivitis. You can give mast cell stabilizer, antihistamine, dual action, combined preparation, and said topical steroid, oral histamine. So let's get started with the mast cell stabilizers, which is, for example, sodium chromoglycate, nidochromyl sodium, lidoxamide must be used for a few days before exerting maximal effect, but are suitable, except lidoxamide for the long term use if required. So mast cell stabilizer basically stabilize the mast cell and does not let it degranulate. So it is one of the treatment that can be used. And what is basically included in sodium chromoglycate, nitochromyl sodium, and lidoxamide. All of them has a longer duration of action except lidoxamide. Antihistamine, for example, amidestine, epinestine, and levocabastine, bipotestine can be used for symptomatic exacerbation and are as effective as mast cell stabilizer. The antihistamines are amidestine, epinestine, levocabastine, and bipotestine, and they are also a symptomatic for the symptomatic exacerbation, and they are as effective as mast cell. Dual action antihistamine and mast cell stabilizer, for example, azilastine, ketotifen, and olopatadine, act rapidly and are often more effective, very effective for exacerbation. So dual action can also drops can also be given in the case, and most important one is the olopatadine. Combined preparation of an antihistamine with a vasoconstrictor, antazolin with a xylometazoline. Basically, vasoconstrictor are used to decrease the chemosis that happens in a case of a allergic conjunctivitis. So that is antazolin with xylometazoline. Non-steroidal anti-inflammatory preparation, for example, diclofenac, can provide symptomatic relief but are rarely used. Topical steroids effective but are rarely necessary. Oral histamine may be indicated for severe symptoms such as diphenhydramine cause significant drowsiness and may be useful in aiding sleep. Others such as loratadine have a far less marked sedative action. So next is a very important topic, vernal keratoconjunctivitis. It is a very, very, very important topic. So one of the things that you will see is the case of a VKC. And why VKC is very important? Because it is one of the predisposing factor for the keratoconus as well. Remember a few points before we start vernal keratoconus. It presents in the childhood, and it is a predisposing factor for the keratoconus, and it causes the papillary conjunctivitis. Pathogenesis. Vernal keratoconjunctivitis VKC is a recurrent bilateral disorder in which both IgE and cell-mediated immune mechanism play important role. So very important, the both eyes will be involved in this case, and both type 1 and type 4 immunity are involved in this. It primarily affects boys, and onset is generally from about the age of 5 years onward. Very important, boys are more affected and 5 years onward age. Basically, allergy is usually, I have seen, more common in boys than in girls. So that is why VKC is also more prominent in boys. There is a remission by the late teens in 95% of the cases, although many of the remainder develops atopic keratoconjunctivitis. Very important, very, very important. Basically, what happen is that usually VKC resolve by the when the teenage settles down. It start at the age of 5 years, but at the teenage it settle down. But some of the cases proceed to the atopic keratoconjunctivitis, which is a adult allergic conjunctivitis. VKC is rare in temperate regions but relatively common in warm, dry climates such as Mediterranean, Sub-Saharan Africa, and the Middle East. In temperate region, over 90% of the patients have other atopic conditions such as asthma and eczema, and two-thirds have a family history of atopy. So basically, in temperate region it is rare, but in those cases, most of the cases are usually associated with asthma, eczema, and his family history of atopy. VKC often occurs on a seasonal basis with a peak incidence over late spring and summer, although there may be a mild perennial symptom. So it occurs in the spring and exacerbate in the spring and in the summer season. So classifications are palpebral VKC, limbal VKC, and mixed VKC. Basically, palpebral VKC occur when there is a primarily involvement of the palpebral conjunctiva. Limbal is when the limbal area is basically involved, and mixed is when it has both the features. Palpebral VKC primarily involves the upper tarsal conjunctiva. It may be associated with significant corneal disease as a result of a close apposition between the inflamed conjunctiva and the corneal epithelium. Limbal disease typically affect Black and the Asian patient. Mixed VKC has a feature of both palpebral and the limbal disease. Diagnosis. The diagnosis is clinical and investigations is usually not required. Eosinophil may be abundant in the conjunctival square. We do not do investigations because it is a case of a clinical diagnosis. Symptoms consist of intense itching, which may be associated with lacrimation, photophobia, foreign body sensation, burning, and thick mucoid discharge. Increased blinking is common. Patient usually present with very intense itching, and there will be the watery discharge, and there can be a mucoid discharge as well. Palpebral disease and limbal disease. Palpebral disease, early mild disease, is characterized by the conjunctival hyperemia and diffuse velvety papillary hypertrophy on the superior tarsal plate. So what happens in the early disease? The conjunctiva will be congested in the palpebral region, and there will be the papillary hypertrophy in the superior tarsal plate. Macropapillary less than 1 mm have a flat topped polygonal appearance, reminiscent of the cobblestones. Focal or diffuse whitish inflammatory infiltrate may be seen in the intense disease. Progression to giant papillae greater than 1 mm can occur as adjacent small lesions amalgamate when dividing septas rupture. Mucus deposition between the giant papillae. Decreased disease activity is characterized by milder conjunctival injection and a decreased mucus production. So basically, first there will be the papillary hypertrophy. When it become more prominent, it become macropapillae, then it become giant papillae, and when the giant papillae have in between the giant papillae, there will be the mucus deposition. The disease is severe. And how do you know that there is a decreased activity? There will be the milder conjunctival injection and decreased mucus production. So let's see figure 6.12. So 6.12 is showing the palpebral vernal disease. A is showing macropapillae with focal inflammatory infiltrates, arrow, and macropapillae with diffuse infiltrates. C is showing giant papillae, and D is showing intense disease with mucus production. Limbal disease. Gelatinous limbal conjunctival papillae may be associated with the transient apically located white cellular collection Horner Trantas dot. In tropical region, limbal disease may be severe. Basically, in case of the limbal disease, there will be the papillae formation in the limbal area, which is usually the whitish cellular collection, and these are known as Horner Trantas dot. So you can say figure 6.13 A and C. A is showing the sparse limbal papillae, B is showing papillae with the Horner Trantas dot. C is showing extensive papillae, and D is showing the severe feature. Now next is a keratopathy. So keratopathy is a corneal disease that occur in conjunction with the VKC. So what are the cornea features that occur? Keratopathy is more frequent in palpebral disease and may take the following forms. So why it is more common? Because the papillae on the uh, cornea, papillae on the conjunctiva rubs on the cornea, which causes the keratopathy. Superior punctate epithelial erosions associated with layers of mucus on the superior cornea. So first there will be the, because it is more common in the superior conjunctiva, so what happens, there will be the superior epithelial erosion and there will be the layer of mucus. Then what happened, that this epithelial macro erosions caused by the combination of the epithelial toxicity from the inflammatory mediator and a direct mechanical effect from the papillae. So then there will be the macro erosion, that will be because of the mechanical effect of the papillae or from the toxicity from inflammatory mediator. Plaque or shield ulcer may develop in palpebral or mixed disease when the exposed Bowman membrane become coated with mucus and calcium phosphate, leading to inadequate wetting and delayed reepithelialization. The development is serious and warrants urgent attention to prevent secondary bacterial infection. So what is a plaque or shield ulcer? Very important. So these are the ulcer that is formed in a case of a VKC, and how it happens when during the macro erosion there will be the exposed Bowman membrane, and in this case it is usually deposited with the mucus and calcium. And what happened when it is deposited with the mucus and calcium, it causes the inadequate or delayed reepithelialization, and you should prevent it because it can cause secondary bacterial infection. Subepithelial scars that are typically gray and oval and may affect vision. Pseudogerontoxone can develop in recurrent limbal disease. It is characterized by a paralimbal band of superficial scarring resembling arcus senilis adjacent to a previously inflamed segment of the limbus. Basically, gerontoxone is basically arcus senilis. Arcus senilis are basically the whitish band that you see in an aging patient. In a case of a pseudogerontoxone, there will be the whitish limbal opacity that will be formed in the superior side of the cornea. Uh, so it gives the appearance of the pseudogerontoxone. Vascularization does not tend to be prominent, although some peripheral superficial vessels and growth is common, especially superiorly. Keratoconus and other forms of corneal ectasias are more common in VKC and are thought to be at least partly due to persistent eye rubbing. So I told you that keratoconus is very important because of the persistent eye rubbing in this case. Herpes simplex keratitis is more common than average, though less so in atopic keratoconjunctivitis. It can be aggressive and is occasionally bilateral. Eyelid disease is usually mild in contrast to atopic keratoconjunctivitis. So you can see 6.14 keratopathy in vernal disease. A is showing the superior punctate erosion and mucus stained with rose bengal. B is showing early plaque in corneal graft. C is showing plaque and shield ulcer, and D is showing the pseudogerontoxone. So atopic keratoconjunctivitis. So atopic keratoconjunctivitis is a disease that occur in basically adulthood, and a patient has a history of an atopic dermatitis. Atopic dermatitis is basically an allergic disease of the skin, and there will be a rash that will be present on the skin of the patient. So usually the patient also present with the eyelid disease as well. Atopic keratoconjunctivitis (AKC) is a rare bilateral disease that typically develops in adulthood. Peak incidence is 30 to 50 years, following a long history of atopic dermatitis, eczema. Asthma is also extremely common in these patients. About 5% have suffered from the childhood VKC. There is little or no gender preponderance. AKC tend to be chronic and unremitting. Very important, it is usually chronic and usually non-remitting disease with a relatively low expectation of eventual resolution and is associated with significant morsal morbidity. Whereas VKC is more frequent, seasonal, and generally worse in the spring, AKC tends to be perennial and is often worse in winter. Patients are sensitive to a wide range of airborne environmental allergens. The diagnosis: the distinction between the EKC and VKC can be made clinically. Eosinophils tend to be less common in conjunctival scraping than with a VKC. Symptoms are similar to those of VKC but are frequently more severe and unremitting. So basically, the AKC and VKC are usually similar, but usually the AKC present in the adulthood, and the patient have a history of the atopic dermatitis, or known as eczema, which is a skin rash that occurs due to some allergy to the environment. Eyelids. So basically, I told you earlier that the skin will be involved because the rash is usually skin related. Skin changes are more prominent than in VKC and are typically toid erythema, which is basically the redness of the skin, dryness. The skin will be a little bit dry. You will feel that the skin is dry and needs some moisturizing. Scaling and thickening, sometimes with the disruption to the epidermal integrity, such as fissioning and scratches. Um, the later due to intense itching, and basically the scratches are due to because there will be the intense itching on that area. Associated chronic staphylococcal blepharitis and medarosis are common. So very important, there will be the associated staphylococcal blepharitis that is associated with the AKC. And medarosis mean loss of eyelashes. There may be the keratinization of the lid margin, Hertoghe sign, absence of the lateral portion of the eyebrows, and Denny Morgan fold, lid skin fold caused by persistent rubbing. Tightening of the facial skin may cause lower lid ectropion and epiphora, and ptosis is not uncommon. So basically, very important, Hertoghe means that the lateral portion of the eyebrow will be absent, and Denny Morgan fold is basically due to the persistent eye rubbing, there will be the lid skin folds. Conjunctival involvement is preferentially inferior palpebral. So whereas VKC it is worse superiorly. So VKC appears superiorly, will his AKC affect the inferior side of the conjunctiva. Discharge is generally more watery than the stingy mucoid discharge in VKC. Hyperemia, chemosis is not uncommon during active inflammation. Papillae are initially smaller than in VKC, though a larger lesion may develop later. Diffuse conjunctival infiltration and scarring may give a whitish, featureless appearance. Cicatricial changes can lead to moderate symblepharon formation, fornical shortening, and keratinization of the caruncle. So whenever there is a scarring changes in the conjunctiva, it can lead to the symblepharon formation, fornical shortening, and keratinization of the caruncle. Limbal involvement, similar to that of a limbal VKC, can be seen including Horner-Trontas rod. So let's see figure 6.15. So 6.15 is showing the atopic disease, is showing the severe lid involvement. You can see the redness on the eyelid. There is a scaling, and there is a keratinization of the eyelid. And B is showing the infiltration and scarring of the tarsal conjunctiva. C is showing the fornical shortening. The fornix is a little bit short, and D is showing the keratinization of the caruncle. So this is a caruncle that has been keratinized. E is showing intense vascularization, corneal vascularization. F is showing the persistent epithelial defect and a peripheral corneal vascularization. A penetrating keratoplasty interface can be seen. So keratopathy is like punctate epithelial erosion over the inferior third of the cornea are common and can be marked. Like in VKC, it's usually upper eyelid. In AKC, it is lower eyelid. Peripheral vascularization and stromal scarrings are more common than in VKC. Persistent epithelial defect sometimes progresses with the focal thinning, can occasionally progress to perforation with desmatocele formation. Plaque formation can occur. predisposition to secondary bacterial and fungal infection, and to aggressive herpes simplex keratitis. Keratoconus is common about 15%, and as with BKC may be secondary to chronic eye rubbing. Because of the chronic eye rubbing, the keratoconus is common in both AKC and VKC. Cataract, presenile shield-like interior or posterior subcapsular cataract are common and may be exacerbated by the long-term steroid therapy. Very important. What type of cataract that can be present in the case of EKC? It is usually the shield-like interior or posterior subcapsular cataract. Because of the high lid margin and carriage of the staph aureus, cataract surgery carries an increased risk of endophthalmitis. This is also very important. We have to treat blepharitis first in case of a VKC, AKC induced cataract. Retinal detachment is more common than in general population and is at particular risk following cataract surgery. So how will we treat the treatment of the VKC and AKC? Basically, the treatment depends on the severity and the chronicity of the disease. If the disease is more severe, we treat it more intensely and with the steroid most probably, and when it is chronic, we give the long-term therapy. The management of the AVKC does not differ substantially from that of AKC, although the latter is generally less responsive and require more intensive and prolonged treatment. General measures are usually allergen avoidance. If possible, allergen, for example, patch testing is sometimes useful but often gives non-specific result. Cold compresses may be helpful. Lid hygiene can be used for associated staphylococcal blepharitis. Moisturizing creams such as E45 can be applied to dry, fissured skin. Bandage contact lens wear to aid healing of a persistent epithelial defect. So, what is the local treatment? Mast cell stabilizer, topical antihistamine, combined preparation, NSAIDs, topical steroids. So, we will discuss it one by one. So, we can treat it locally. Locally, mast cell stabilizer are sodium chromoglycate, nitrochromial sodium, and lidoxamide reduces the frequency of acute exacerbation and the need for steroid. So form the basis of many regime but are seldom effective in isolation. Several days to weeks of treatment are needed for a reasonable response, and long-term therapy may be needed. Lidoxamide is not licensed for the long-term use. We can give the mast cell stabilizer, but these are usually it only reduces the acute frequency but not for the long-term use. Topical antihistamine, amidestine, epinestine, levocabestine, bipotestine, when used in isolation, are about as effective as mast cell stabilizer. They are suitable for acute exacerbation but are generally not continuous long-term use, and courses of several preparations are licensed for use only in the course of limited duration. A trial of several different agents may be worthwhile. So basically, mast cells and topical antihistamines are given when usually you require an acute treatment to acute exacerbation of the VKC or AKC. Combined antihistamine and vasoconstrictors, for example, entazolene with xylometazoline, may offer relief in some cases. Combined action antihistamine or mast cell stabilizer, for example, azilistine, ketotifen, and olopatadine, are helpful in many patients and have a relatively rapid onset of action. Non-steroidal anti-inflammatory preparation, for example, ketorolac, diclofenac, may improve comfort by blocking non-histamine mediator. Combining one of these with a mast cell stabilizer is an effective regime in some patients. Topical steroid, for example, fluoromethanol 0.1%, remoxolone 1%, prednisolone 0.5%, loteprednol, etabonate 0.5 or 0.5% are usually for the severe exacerbation of conjunctivitis and a significant keratopathy. Reducing conjunctival activity generally leads to corneal improvement. They are usually prescribed in short but intensive to early initial courses, aiming for a prompt tapering. Although the risk of elevation of the intraocular pressure is low, monitoring is advisable if long-term treatment is necessary. Stronger preparations such as prednisolone 1% can be used but carry a high risk of steroid-induced glaucoma. Shield ulcer are often uh, refractory to topical steroid treatment. So basically, when we use steroid are usually used when the disease is very severe and acutely present. What we can give the steroid preparation, prednisolone 0.5%, loteprednol 0.2 to 0.5%, and they are usually given intensely, and then with the response to the treatment we taper the steroids accordingly. But with the steroid use, one thing you must have been is the IOP, or steroid induced glaucoma, which usually present 3 weeks after the use of the topical steroid. So one must be very careful when you are using the steroid for the longer period of time, and you should monitor the IOP with that, especially in case of the children. It is a very common phenomena that has been reported. Steroid or ointment, for example, hydrocortisone 0.5% may be used to treat the eyelid in EKC. Though, as with the eye drops, with the duration of treatment should be minimized and the intraocular pressure monitored. Antibiotics may be used in conjunction with the steroid in severe keratopathy to prevent or treat bacterial infection. Acetylcysteine is a mucolytic agent that may be useful in VKC for developing dissolving mucous filaments and deposits and addressing early plaque formation. Immunomodulator. Immunomodulator is basically cyclosporin, calcineurin inhibitors. So cyclosporin is 0.05 to 2% between 2 to 6 times daily, may be indicated if steroids are ineffective, inadequate, or poorly tolerated, or as a steroid sparing agent in patients with severe disease. This effective typically takes some week to be exerted, and relapses may occur if treatment is stopped. Suddenly, irritation and blurred vision is common. So basically, steroid immunomodulators are the steroid sparing agents. So we use cyclosporin, which is usually 0.5 to 2%. But one is that it has a very longer duration of action. It takes some time to act. So before that, we use some steroid to let the cyclosporin to act. So one thing, and relapse occur if the it is stopped, treatment is stopped. So you have to give for the longer period of time. Calcineurin inhibitors show an increasing promise as an alternative to steroid in the treatment of allergic eye disease. Tacrolimus 0.03% ointment can be effective in AKC for the severe eyelid disease. Instillation into the fornix has been effective in modulating conjunctival inflammation in refractive cases. Refractory cases, tacrolimus 0.1% ointment is particularly useful when applied topically in patients with a shield ulcer and corneal epitheliopathy, and can be used without topical steroid. Factors associated with poor response to topic tacrolimus include the presence of the giant papillae and the palpebral abnormality. So, calcineurin emitters are tacrolimus ointment, and they can be used in a case of a severe refractory cases, especially in a case of the shield ulcer and corneal epitheliopathy. Supratorsal steroid injection may be considered as a severe palpebral disease or for the non-compliant patient. The injection is given into the conjunctival surface of the anesthetized in everted upper eyelid. 0.1 ml of betamethasone sodium phosphate 4 mg per ml, dexamethasone 4 mg per ml, or triamcinolone 40 mg per ml is given. Topical steroids should not be used long term in a patient with allergic conjunctivitis without monitoring the IOP. So when we give that supratarsal steroid injection, so we give the local anesthesia to patient, a local topical anesthesia, to the patient, and then we invert the lid, and then we take the 1 ml syringe, and we give the uh, 0.1 ml of betamethasone, or 4 ml dexamethasone, or triamcinolone 0.1. And basically it is used for the cases of, and there will as a severe papillary conjunctivitis, giant papillae, and for the non-compliant patients. Then there is a systemic treatment. Then there is a systemic treatment. Oral antihistamine help itching, promote sleep, and reduce nocturnal eye rubbing. Because other inflammatory mediators are involved beside histamine, effectiveness is not assured. Some antihistamine, for example loratadine, cause relatively little drowsiness. So what can you give? Oral antihistamine, and that prevents the nocturnal eye rubbing and promotes sleep. Antibiotic, for example, doxycycline 50 to 100 milligram daily for 6 weeks, azithromycin 500 milligram once daily for 3 days must be given to reduce blepharitis, aggravated inflammation, usually in AKC. So when there is a blepharitis that is associated with AKC, you can give oral tetracycline. Immunosuppressive agent, for example, steroid, cyclosporin, tacrolimus, azathioprine may be effective at relatively low doses in AKC and responsive to other measures. Short courses of high dose steroid may be necessary to achieve rapid control in severe disease. Monoclonal antibodies against T cells have been shown some promises in the refractory cases. So basically, AKC is a refractory disease and usually do not respond well to the steroid. So one can give the oral immune modulators with the GP consultations. Other treatment that may be effective in some patients include aspirin in vacancy, avoided in children and adolescents due to Reye syndrome risk, allergen desensitization, and plasmapheresis in patients with a high serum IgE level. So these can also be used. So when we do surgery to for the corneal diseases and when there is a conjunctival cicatricial diseases in the cases of a conjunctivitis. Superficial keratectomy may be required to remove plaques or debris shield ulcer and allow reepithelialization. Medical treatment must be maintained until the cornea has reepithelialized in order to prevent recurrence. Excimer laser phototherapeutic keratectomy as an alternative. Surface maintenance or as restoration surgery such as amniotic membrane overlay grafting or lamellar keratoplasty or eyelid procedures such as botulism toxin induced ptosis or lateral torsography may be required for severe persistent epithelial defects or ulceration. Gluing may be appropriate for a focal or punched out corneal perforation. So surface procedure maintenance procedure are usually depending on the types of the eyelid disease that has been present. So you can do if there is a persistent epithelial defect, you can do keratoplasty, lamellar keratoplasty, you can put the amniotic membrane, you can do lateral tarsography in a case of that. And when there is a corneal perforation, you can do gluing as well. Non-allergic eosinophil conjunctivitis. Non-allergic eosinophil conjunctivitis (NAEC) is a recently proposed chronic non-atopic condition said to occur predominantly in middle-aged women in whom dry eye is also commonly present. So it is present in middle-aged women and dry eye is common. It has been suggested that this is relatively common but underdiagnosed. It is thought to be of a similar pathogenesis to the non-allergic eosinophilic rhinitis. Conjunctival eosinophilia is present without significant IgE levels in the serum or tear film. Symptoms are similar to those of allergic conjunctivitis: itching, redness, foreign body sensation, and mild watery discharge. Treatment is with 1 to 2 weeks course of the topical steroid for exacerbation, followed by the maintenance with the topical mast cell stabilizer, non-steroidal anti-inflammatory agent, or antihistamine. Contact allergic blepharoconjunctivitis. Analogous to the contact dermatitis. So you can see contact means some contact has been occurred to the conjunctiva that causes the allergic disease. So it can be due to some kind of a topical medication, contact lens, or anything chemical. This refers to the subacute, acute, or subacute T cell mediated delayed hypersensitivity reaction seen most commonly by ophthalmologists as a reaction to the eye drop constitution and by optometrists as a result of a contact lens solutions. Mascara is a less common cause. There may be a conjunctival reaction, but signs predominantly involve the eyelid skin, erythema, thickening, and duration, and sometimes visioning occur. Treatment is by the discontinuation of the precipitant. A mild topical steroid ointment can be helpful. So you can see figure 6.16 with that. It is a contact lens allergic conjunctivitis. Eyelid is also involved. Next, there is a giant mechanically induced papillary conjunctivitis. So, some mechanical thing is present in the eye that causes the giant papillae reaction in the conjunctiva. It is basically some kind of suture that is present. It can be due to the contact lens that is present, or it can be due to the bleb. Pathogenesis: mechanically induced papillary conjunctivitis, the severe form which is known as giant papillary conjunctivitis, can occur secondary to a variety of a mechanical stimuli of a tarsal conjunctivitis, more frequently encountered with the contact lens, where it is termed as a contact lens associated papillary conjunctivitis. So one of the its entity is the contact lens associated papillary conjunctivitis. The risk is increased by the buildup of a proteinaceous deposit and cellular debris on the contact lens surface. Other ocular prostheses, exposed sutures, scleral buccal, corneal surface irregularities, and filtering bleb can also be responsible. A related phenomena is so-called mucus fishing syndrome, when in a variety of underlying anterior segment disorder, patient develop or exacerbate a chronic papillary reaction due to a repetitive mechanical removal of a mucus. Uh, Giant papillae can also be seen in other conditions such as VKC and AKC. So there will be the papillae formation due to the mechanical presence of something foreign body, like you can see the bleb is present, suture is present, contact lens is present. It causes the reaction in the conjunctiva, which is a papillary in nature. Diagnosis: symptoms consist of a foreign body sensation, redness, itching, increased mucus production, blurring, and loss of contact lens tolerance. Symptoms may worsen after lens removal. Patient may be required may should be questioned about the contact lens cleaning and maintenance. So what are the signs? Are the signs of the variable mucus discharge? Substantial contact lens protein deposit may be present. Excessive contact lens mobility or due to upper lid capture. Superior tarsal hyperemia and papillae. By definition, the giant papillae are greater than 1 mm in diameter, but the clinical syndrome of mechanically induced papillary conjunctivitis commonly feature only fine or medium papillae, particularly in early or mild disease. Focal apical ulceration and vitis scarring may develop on large papillae. Keratopathy is rare because of the relatively subdued secretion of the inflammatory cytokines. Ptosis may occur as a result of a irritative spasm and tissue laxity secondary to chronic inflammation. So what will be happen? There will be the mucus discharge, there will be the contact lens protein deposit, and due to the upper lid capture, contact lens mobility will be increased. There will be the superior typal hyperemia, which is basically it is named. There will be the giant papillae, that it will be greater than 1 mm in diameter, and there can be the uh, ulceration in the papillae as well, and keratopathy can also occur, and ptosis can occur. So how do you treat? So one of the thing is you have to remove the stimuli, and then you treat the papillae by mast cell stabilizer or the reaction that causes in the papillae. Treatment: other causes of conjunctival papillae should be excluded, and as well as contact lens intolerance due to other causes such as reaction to lens cleaning solution and dry eyes. Removal of stimulus: contact lens wear should be discontinued for the several weeks and the current lens is replaced. So one of the things is you have to ask the patient to remove the contact lens for several weeks. For mild to moderate disease, this may be adequate for resolution, sometimes in conjunction with the reduced wearing time. In severe contact lens papillary conjunctivitis, a longer interval without her lens wear may be needed. Removal of other underlying causes such as exposed suture or scleral buccal. Assessment of the status and the fit of an ocular prosthesis. Filtering pleb. Partial excision revision with a non-penetrating drainage surgery or glaucoma drainage device implantation. So in a case of a filtering bleb, you can do another surgery to remove this the stimuli. Ensure effective cleaning of the contact lens or prosthesis. Changing the type of contact lens solution, particularly discontinuation of the preservative containing preparation. Switching to a monthly then daily disposable contact lens if the condition persists after renewing non-disposable lenses. Rigid lenses carry a reduced risk of a contact lens papillary conjunctivitis, 5% probably. They are easier to clean effectively. Cessation of the contact lens wear, substituting spectacles or refractive surgery may be necessary for severe or refractory disease. Regular, at least weekly use of the contact lens protein removal tablets, prosthesis, polishing, cleaning with detergent and coding. Topical is a topical treatment we have to give to reduce the papillary conjunctivitis. Mast cell stabilizers should be non-preservative patient wearing soft contact lenses and can be instilled when the lenses are not in the eye with a delay of perhaps half an hour after drops installation prior to lens insertion. Most can be continued long term if necessary. Antihistamine, non steroidal anti inflammatory agent, and combined antihistamine and mast cell stabilizer may each be of benefit. Topical steroid can be used for acute phase of resistant cases, particularly those with where effective removal of the stimulus is difficult, as in pleb-related disease. So that's it for the cases of the allergic conjunctivitis. See you in the next lecture. Thank you very much.